All right, I'm going to call the meeting to order. It's June 23rd, 2026, and we have a quorum. I would entertain a motion on the consent agenda, if everybody's had an opportunity to review that.
I so move.
Thank you. Is there a second?
Second.
All those in favor?
Aye.
Aye. Medical staff summary. Dr. Devine?
I think we have two of them to summarize.
Goodbye.
So much for that, Sarah.
So the first was the May 12th meeting. There was a note that there was a dip in positive sleep study tests. A lot of people are trying to get sleep studies done so they can get GLP-1s. And so more tests have gone through than was necessary. So we reviewed that the criteria for testing should be stuck to fairly closely. Nicole reported an OR upgrade in both, this completed both operating rooms. Dr. Bodendorfer would be coming back to us from, because he now joined MD West 1. We were going to have an announcement for the first set of grants for recruitment on May 22nd. Siemens was selected as the vendor for the in-house MRI, and further I'm sure will come through Jeff. And then we have the appointments and reappointments. Claire mentioned the spring upgrade, which was Friday, May 15th at midnight.
Welcome to Zoom.
We
Enter
did
your
also
meeting
have
ID.
an educational on May 19th on care of patients with LVADs, and I actually brought one. And that was pretty nice to see how it goes on and off, because that's not something you
Enter your
actually have
participant.
a manual that comes with the patient.
What does that acronym
You
stand
are
for?
in the
It's
meeting
left
now.
ventricular system
There
raise,
is one
so
other
it actually sits
participant in the meeting.
in and pushes blood through
Okay,
for people who are either awaiting transplant or are refractory heart failure patients.
okay.
So Kyle had mentioned that there was a physician wondering if Myrtue was interested in accepting residents from a medical school in Wichita, and we agreed that we would be happy to do that. That was May's meeting. Then to June. June, we had a discussion on the standing order for pediatric patients presenting with obvious deformities. This is the fractures. There is an intranasal fentanyl protocol that's used by children's that we want to adopt so that they can get pain relief before we further examine them, because obviously kids are already scared and have extra pain. That's not pleasant. We discussed a virus going around Elm Crest, which does seem to be quite affecting the elderly. So patients who were coming within that time frame when the virus was going around would put in droplet isolation just to keep everyone protected. We discussed the Shield test, which is another option for testing for people DNA for colon cancer. Our GI prefers colonoscopy as standard of care, which it is. But if it was between Cologuard or Shield, preferred Cologuard. Kim then gave another presentation regarding GLP-1s and what areas will. So when the government came out and announced that all GLP-1s would be $50, we had a big influx of people who wanted to go on them, who were not eligible. That's only for Medicare, and it's only for qualified individuals. And so we had a whole bunch that wanted us to just resubmit it to my insurance. I want to make sure. And obviously our court authorization just got a little overwhelmed. We did apply for a grant for recruitment. We should know about that by the end of June. We discussed changes to the medical staff peer review. And currently we have where every 3 years or more, just random charts go to Methodist for peer review. Most of those come back as a level 1, meaning everyone would have done the same thing in the same circumstances. And they go to the same peer type people. So for internal medicine, it goes to internal med, for surgery, it goes to a surgeon, and then it comes back to us. These were all being reviewed as part of our med exec committee. And if they're level 1, which means that was a little bit excessive. So now I can, as chief of staff, sign off on them, and then the future chiefs of staff can sign off on them, and not have them go to a secondary review. Medical staff voted to approve those changes. And we have the appointments and reappointments for June, which are in your handout. It was mentioned Methodist Jenny Evanson's new mental health hospital is not open yet, and so currently they are having a difficult time taking mental health patients because they're trying to get things moved over to their new facility. That'd be it.
Thank you.
Thank you.
Any questions for Dr. Devine?
Thank you.
Thanks very much. Okay. Quality improvement report, Laura?
Okay, 15 departments reported at the May 20th system-wide QI meeting. A few department highlights are that diabetic education reported a 2% reduction in hemoglobin A1C levels after education. Infection prevention reported 0 healthcare acquired infections. Pharmacy reported 0 adverse drug events. Respiratory therapy reported 100% of our orthopedic surgical patients are receiving RT education prior to discharge. Utilization review reported no sepsis mortality. And rehab services is really working hard on getting our outpatient evals completed within 24 hours after prior authorization. So that prior authorization comes through and within 24 hours, we want to have that eval done. And they reported that PT was at 94%, OT at 93%, and speech at 100% of that goal. So good job there, and that's all I have.
Thank you. Any questions for Laura? Okay. So Nicole, as Chief Nursing Officer, I think go ahead.
Would it be okay with you all to have Shay go first so she can get back to her
Oh, for sure.
department and give a little robot update?
Yeah, that would be great, Shay.
So I just have a little update on our robot. So it's just kind of a little overview and some of the stuff we've been through. The robot actually consists of 3 different parts. On the left there is where the surgeon sits during the procedure, gives them a 3D view, and they have their little finger things that they're working through. That middle piece is what the instruments go into, that goes into the patient, and that on the right is the vision cart, and it supports all the communication between those components. And there's a viewing screen and it has the generator on that for cautery. So staff has completed a bunch of training. They did some online and on-site with Intuitive for a couple days prior to the first procedure. We did a dry run with Dr. Garvin. Gabby Linen went to Chicago for her first assistant training with Intuitive. They continue to support cases as needed, and they will come do hands-on training with new staff. There's all 24/7 live support. They can remote in and see what we're seeing and see what's going on if something's not communicating quite right. We did add some pieces to the sterile processing department, and with that, it's a little bit bigger of an undertaking to process some of the stuff, so we did add a new staff member, and that is going really well. Workflows are just a little bit different with everything that goes with the robot, so get the room all set up before the patient gets in there. So that's just putting the thing where it needs to be, getting it all draped, making sure that the robot is set to the anatomy that we're doing, and that will affect how it rotates and comes in. We got to pick the correct instruments. There's a bunch of different instruments that all have a different amount of uses they can do. And then once we're all ready to go and hook the robot up to the patient, we drive it on in and get to work. So there's just a little video that kind of show that process. That's them driving the robot into the patient. The surgeon stays scrubbed in for this part.
As a disclosure, this is not RT. This is just a YouTube video.
Oh,
Yes.
they do it very quickly, so it's a good choice. It prompts them the steps that they go through. Lots of noises. They must have been competing.
Yes.
So that's just getting everything to where it needs to be, and then the surgeon would break scrub and go sit up in the robot and do their procedure.
And it is like a little video game. I mean, truly, they put like 2 fingers into the robot, and the tiniest of movements makes the robot move.
Did we see the surgeon actually in that video clip?
The surgeon was at the field.
Okay. But
Helping
wasn't
get-
advised as.
He wasn't in the console. Nope.
So how many of these procedures have you done so far?
It's on the next slide.
Oh, sorry.
So
Shut up
this
and
was, it's been updated since then. So we've done 137 cases since April of last year. There's been 108 general surgery cases and 29 gynecology surgeries. The average times that we spend under the robot for general surgery is 76 minutes and gynecology is 88 minutes. So they're rocking and rolling really well with that. 2 to 3 cases a week. We've done 3 in 1 day though, so it's good for our staff. It's busy.
Any downside to the robot?
No,
It's
not
all
really.
good.
Just the processing of it takes, after we're finished, about 3 hours to get those instruments cleaned
Yeah.
and to the sterilizer to be reprocessed. So that's a little bit of a change, kind of makes it difficult at the end of the day, which is why we added that new staff member. She comes in a little bit later and stays a little bit later for those later cases.
And I'm just curious, does it use the same instruments that the surgeon would use, or are they special for the robot?
They're special for the robot.
Okay.
Future, hopefully keep expanding our volume and evaluate potential additional service lines, such as urology, if that's ever in the future. We'd love to do some more with that. Keep working on our optimization and efficiency. I know that there's always stuff that we can improve on and get a little bit better at, and enhance the staff education, get some more of our circulators trained to scrub in with the robot. It's, in addition to learning how to scrub, the robot's a whole nother layer to that, so just getting them trained. That's it.
I do want to give Shay a kudos because she onboarded as the perioperative director like the exact time that we were rolling out the robot. So she did a great job of stepping in and making sure that everybody knew what was needed and has just kept pushing it forward. So thanks, Shay.
I'm just curious, are there more staff members in the surgery than there used to be? It looked like a room full.
It's nice to have extra people at the beginning before you get docked, because there's so much happening. There's a lot of plugging in and unplugging things, kind of switching stuff, so that we have to switch some things so that you can switch from the normal camera to the robotic camera. So it is nice to have somebody kind of doing that and then taking care of getting the robot to the patient.
It's just additional preparation and then a little bit more on the back end.
Yeah.
Once everything is finished.
And then it is nice, kind of at the end, if somebody's able to come in and start getting the robot undraped just to help with turnover. That way somebody can focus on that, somebody can focus on taking care of the patient. Just a little bit of efficiency.
That's great. Thank you, Shane. All right, go
All right.
ahead. Yeah.
So moving on, we do have one action item, and that is joint conference that took place on May 19th. So at that point in time, from a disaster planning standpoint, Kathy Buman had shared that we had received some grant monies for disaster planning. So she had purchased some incident command radios, additional N95 fit testing kits. She was able to get attendance to the Iowa ENA conference and to the IONL conference paid for all the nursing staff that were going to attend those. She also purchased some exercises for violent intruder and cybersecurity, and reported that we've just been continuing to plan for RAGBRAI moving forward. And I'll share a little bit more about that here after this. From a trauma standpoint, Jenny shared that we submitted our final recertification as a level 4 trauma center, so awaiting that information to come back. And with that, we've been just working to improve and streamline our mass transfusion policy, which is used if somebody were to come in hemorrhaging, bleeding. And so that takes a lot of coordination between like our ED staff and our lab staff to make sure that we're getting that done timely. Jenny also shared we continue to use our telestroke machine from a stroke standpoint, from a pediatric standpoint. I know you guys have heard this before, but Bailey Ertz is our pediatric coordinator in the ED as part of her clinical ladder. So she is continuing to put in data into that system through Texas and in order to get like some best practice recommendations back to us. So we continue to work through that. Some of the information that Dr. Devine shared about the pediatric intranasal fentanyl for obvious fractures kind of came out of that. So it's been effective and helpful so far. And then we are also entering into a contract with Children's Omaha as part of a pilot program. We're hoping that this will start in the fall in this year, 2026. And that is just going to help us. Like if we have a pediatric patient in the ED, as it stands, it would just be ED. We can reach out to Children's, which we do already through phone, but this would then provide like a telehealth service and kind of help us take care of that patient until they can then get transferred out of here. We're also hoping that maybe this telehealth will help a little bit to be like, hey, maybe you can keep them there and we need to do X, Y, and Z while they're there. It's just sometimes nicer for them to visualize the patient versus just a phone call where you're trying to communicate that way. And then we will recertify as pediatric ready in the next, in 1.5 years from now. From a cardiac standpoint, Jenny shared that Jenny Ed received monies through those RHT grants as a cardiovascular and chronic disease center of excellence. So they had reached out to us to work with us and just see like what can we continue to provide you or provide you beyond what we're already doing to help you with those types of patients that are coming through. Jason in the lab shared that January to March 26, we had 3 events with no failures, and that was with over 500 charts being reviewed. Nancy shared some formulary revisions and some also shared that we've had some recalls, but all of those were received and any of the items that we had on our shelves were removed and sent back to the company. She also reported that we'll be switching to a ready-to-use Banco infusion, which is an antibiotic, and this will be could be used with a pregnant patient. So that will be good. It'll be for use with everybody now. And Tina reported that hospice had their DIAL survey, and that took place in April and May. And DIAL accepted the action plan for any deficiencies that were noted, and then they'll just follow up because they'll have their home health survey here soon as well. Lippincott, I had nothing to report at that meeting. And then we went through all of the policy and procedure reviews for the departments that presented for an annual basis and then quarterly, and those were all approved. Also went through ethic order sets because those have been added to joint conference, which were approved. Laura reported on core measures. Quality and compliance is currently at 79%, which gives us a goal score of 3, and patient experience was at 83%, so a goal score of 4. And we adjourned at about 7:30 and then started our infection prevention meeting. So
Sounds like you've been really busy, Nicole.
it's
Wow.
not me. It's all the departments.
It's a team.
So yes,
Yeah.
I can go ahead and pass this around, but I do need formal approval for that, please.
So I'd entertain a motion for the consideration of the approval of the joint conference committee meeting, policy and procedure revisions.
I'd make that motion.
I'll second it.
All those in favor?
Aye.
Aye. Opposed? Okay. Thanks, Jim.
And then I just have a couple of other items here. I wanted to let everybody know that Dr. Bodendorfer with MD West 1 started in May 27th or somewhere right around there. So he started seeing patients. That brings us up to 5 providers, which are kind of like full scope really right now. So sports med, hand, total joint, shoulder, and foot and ankle. So that's giving us about 11 to 13 days of coverage with orthopedics every month, which is fantastic. They have moved into their new space, which was the old cardiac rehab space. So that is functioning very well, and all the ortho team loves it down there. Yeah.
Good.
Dr. Sherrod did notify us last month that he was going to be retiring. He's our current ENT practicing physician here. And so he gave us about a 1-month notice, but had done some legwork up front to kind of help us out with that. So his last day is today as a full-time provider, but he is going to continue to come here on a part-time basis. So he will come 2 times a month versus his weekly coverage. And that will be then supplemented. We are going to be getting Dr. Medeiros back here at Myrtue from ENT Consultants, so they will practice together. And the goal is that that will start by next week or the following week and be kind of a seamless transition then for our ENT patients that are coming to see them. We continue work on the MRI project through that Rural Health Transformation Grant. So plenty of meetings on that, all good meetings, and I feel like we're moving forward very well. As mentioned, Dr. Devine said the OR integration was complete with our new lights, booms, and screens, and the surgeons are very happy and all is well from that standpoint. And lastly, we do continue RAGBRAI planning. So as it stands right now, we are kind of staffing the hospital quite heavy just in case we are overflowed in the ER. Some of our patients can then go to our pre and post-op area and we'll have a team down there to take care of like maybe somebody that just needs fluids or dressed, that sort of thing, for bandages and whatnot. And then our call staff has been asked to be within Harlan, Iowa during that time because it will be difficult to get here. And then Tina and Kim have worked together, Tina with Community Health, to put together 2 first aid stations. So we'll have a first aid station at the library up around the square and then also one at the high school because that will be the campground for the Vipers. So.
Yeah, it's been a long time, so I don't know if we even have notes from 13 years ago.
Yeah.
So, yeah.
Well, I've been asking Karen a few questions.
Yeah.
And Jenny was here for that as well, so that has been helpful. But
It is helpful.
you guys have any questions for me?
Thanks a lot. Appreciate all that. Yeah. Okay, Kim, you're up. Tell us about what's happening in the clinic.
I'm going to jump onto Nicole's real quick since she ended with Ray, but I just let everybody know, we will be delaying start on that Monday, July 20th, just to kind of allow the traffic to clear out and not create more congestion around town. So we will delay our start time until 11 a.m.
Okay.
So we are prepping to move back into the existing first floor of the clinic. Lots of work has happened. Our maintenance department has worked long and hard hours after the construction folks had vacated that area. And we're going to start first with Dr. Jones, getting her moved back into her space. And we're anticipating that she will start seeing patients out of that new area on June 30th. So
Great.
hopefully go over going. And then the last thing that I do have for you guys today is to inform you that Nicole Toplick, she had been doing 1 weekend per month for the last year or so. She has turned in resignation. And so her last shift here will be on July 5th. And then she will be finished with it. She did move out to Nebraska. So it's like a 3.5 hour drive every time she comes here. And so was just doing 12 hours per month. And so she's decided that maybe those 12 hours can be used elsewhere.
What about coverage for that? What are you planning?
Currently, I've been very fortunate that a lot of our staff is willing to pick up. But we'll be working with Jill and with Kyle to get some information out there and get the coverage for that we need.
Yeah, great. Any questions for Kim? I don't know what you're gonna do when you're not moving walls and having hammers and all.
I guess I should make mention that then after Dr. Jones gets transitioned, and then we'll be transitioning our weekends and evening clinic back into that space.
Yeah.
And then
That would be
Dr.
it.
Kelly Anderson and Jennifer Brooke, the women's health side, is going to join us on the first floor until the second floor is completely done and ready to go. As it's just beneficial to have them as part of the mental health side.
Oh, I would agree. Yeah, that's great.
So a few more months of moving around and adjusting, and then things will kind of settle in for a little bit. That's good.
Jill, can you give us an update?
Yeah. So Dr. Devine had mentioned that we had applied for a workforce recruitment grant, and that fell under the Rural Health Transformation grants that we had applied for earlier in the year. So we just actually received notice yesterday that we did receive the grant that we applied for to recruit an MRI technologist. So that goes hand in hand with our new in-house MRI that will come into place. And we'll need to recruit and have that MRI up and running by September of 2027. So we'll be recruiting for that here shortly. It could take us some time. So that is on the forefront. We are also expanding our anesthesia team due to growth in OB services, women's health, OR services, like you saw with our robot. So we are positioning ourselves to recruit an additional CRNA, and we are doing some interviews for that already. That's taking place this week. And then as far as recruitment, so we will be recruiting for Nicole replacement. We're looking at some varying options for that, but we're also still recruiting for an FMOB to join the practice. I've shared with the board for multiple months that we've been in conversations, and those conversations continue. So
No signatures, just
we're getting
conversations.
closer. No signatures, but we're getting closer. We're also visiting with an OBGYN, so just having some of those logistical conversations with Dr. Kelly Anderson and the candidate with whom we are visiting with.
Thank you.
Those all appear to be promising at this point.
FMOB appears very promising at this point, but I keep telling Kyle and others I'm gonna jinx us if I keep saying how promising it is. And then, yeah, we don't have pen to paper just yet, but we're getting there.
Okay. Close.
Close. Any questions for Joe? Okay, Jeff?
All right, follow up on a couple more things. As we were talking about the RHC, the maintenance and IT staff have been moving all of the, tables, mounting all the otoscopes and everything in there to get ready. Computers are all placed, ready to go. We've got a couple more network runs that need to be installed, and then everything should be ready to go. Have a couple punch list items, like a couple carpet tiles need to be replaced. They got glue or something on them. We can't get it off. So a few minor things like that need to be taken care of. Last week, I believe it was, the business office moved down to our Morning View Drive location. Maintenance staff spent a lot of time down there leveling the floor, which was 3/4 of an inch off from one corner to the other. So we got everything leveled off, new flooring, painted everything, new lights, looked really good. IT moved all of the computers and printers down there. We had to add a network switch to get that configured for the additional capacity. So everything went pretty well there. We do have a second phase of that on the east side. They moved in, the current staff moved into the center and the west half.
How many?
How many? A bunch. 20?
Oh, it's gonna be 23 eventually down there.
Yeah. Yeah. So a good number of people. There's three offices on the north. That'd be 6, 9, 3, 4 people in the middle is 10. A couple, 3 business offices is 13. Then we had 4 in the center. So 17 people moved. And then we have a few more where the intent is when we first moved into that building, we had the previous owner build some offices, and they were kind of temporary. So whenever we moved out, they could be reconfigured with minimal damage. We're going to go in and reconfigure all that again to better support the functions that we're going to have moving down there. So a little bit more work. That does take supporting a back door to the second floor RHC. So that'll be coming up. I'm not sure if you drive by the Wellness Center across the street, there were 2 or 4 parking spots that were blocked off. We had an undermine under there. It's the storm sewer drain. Had some dirt undermined, and it was a pretty big hole there. So found out that the pipes underneath, there were 2 broken pipes. So we got those repaired, fixed, backfilled, and now we're just waiting for the concrete to cure finally, the final cure on that. And so that'll be open. later this year, we're hoping to replace all of the concrete over there in front of the wellness center and physical therapy. It's crumbling and it's kind of getting in bad shape. Microsoft 365, we finished that transition a couple weeks ago. Did have a couple anomalies that we got worked out. We still have a few things that, security-wise, we've got very tight security. We need to figure out what is the appropriate level to go. So any of our emails, when they go out, they're checked for, the far end is checked for security. And if the security on that far end is not where it needs to be, it encrypts, it has an encrypted message and says create a user password. You can get in and read this email. And so we're running into that quite a bit. So it's not our side, it's the other side, but we also have to come up with what's the appropriate level to send out. As I said, the MRI design is going well. The detailed design documents have been finalized. Now we're on to construction documents, which will be those documents that go out to the bidders. At the next board meeting, we should have a GMP, guaranteed maximum price for the whole project, and probably be asking for approval to move forward with that project at that time. That's pretty much it on an update. And the last thing I have is on the existing project that we're working on, one of the last items that the board has to do is approve substantial completion. We have worked with the contractor, the architect, and us, and substantial completion is the work construction zone is at a condition that we can get in and perform the function that it was designed for. Not that everything is totally fixed, but we can get in and work. So there's a few paint patches that need to occur. There's 2 or 3 doors that were miscut and are in order to come back in late July to be installed. But for the most part, everything is at a level that we could perform the function it was designed for. There is still a punch list. On page 34 of your your packet is the AIA document that talks about it. There are 3 items in here that need to still be completed and they're actively being worked on. The med-surg punch list, a final punch list was created, and then the phase 2 punch list we've gone through. Last week actually went through once again to punch and make sure everything is done. We're down to about 100 items, and like 20 of them are paint. We want this little nick fixed and that nick fixed, but to have to paint the whole wall. Getting closer on those, we have some company called IDC has to come in and do a little bit of, put a couple of corner guards on. So they're very essentially minor items. So the architect has certified as of June 12th, last Friday, a week and a half ago, that the construction has progressed to a point that we feel substantial completion has been accomplished. We agree, and like I said, we still have a number of items that will get fixed over the next month, but we do need board approval to accept the substantial completion. And what happens there then is there's a 30-day protest period that any of the subs can file a grievance against the project, and there's a process to follow along that line. And then it also starts our warranty period for guarantees, for the equipment and everything there. So, and that's just a 30-day time frame. So with that, I would request approval of substantial completion.
Any questions about the substantial completion? Okay.
I make that motion.
Jim made the motion.
I'll second.
Second.
Yes.
All those in favor? Aye.
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 Okay, thank you. I do want to roll back on the GMP.
Yep.
Are you just going to ask Marie for that?
Yep.
Have you already determined that?
The MRI, due to timing of the grant, we are doing a change control to the overall project that we are just finishing. So it will be an amendment to the existing contract. It'll have its own timeline, its own process. We will have substantial completion on that also to complete. So just because we have to basically be done in a year from now, have the facility done so that we can get in, configure the MRI, do the training on the MRI, and start seeing patients as of early September. So it is an amendment to the existing contract, and to make it faster, stay with Murray, stay with most of the subs. They still will do competitive bidding and everything, but that was going to be the fastest. Otherwise, we had to go out, get a new CMAR, go through the whole process, and we felt did not have enough time to do that.
Okay, I mean, there's been pluses and minuses about
Absolutely.
every contractor, and I just wanted to ask how you felt about that. I don't know, Kyle, you're kind of new to this process.
I don't have any overall complaint.
Okay,
I mean, comparing our current contractor to the one I worked with in something for blessed.
okay, all right.
And we have, reached out, talked to the CAS about their projects. They have a different CM.
Mhm.
We've talked to, quite a number of other area hospitals. I mean, clear over to Nevada and such on the projects they're doing. They're having the same experience with their CM. So
Sure.
it's, the next project we do feel we have to go out for a new CM contract.
Yeah, I think that, I mean, there's pluses and
Yeah.
minuses to everything, and I feel like they've lived here for about 4 years now.
Pretty close. It has been close, yes.
They should have bought a house.
Yeah. So no, like you say, there's great things and there's some things we.
Have been disappointed in, right.
Yeah.
But in general, in regard to the MRI being up and functional a year from September, what's the general feeling about that? Obviously, it's all doable, but
If they stick to their timetables, which they have presented us, it should not be an issue.
okay.
And we have asked for that amendment we discussed before that would have penalties for them not hitting those. They have not presented that amendment yet, but we discussed that today. It should be forthcoming.
Okay, great. Okay, didn't mean to slow you up,
Oh,
but
no.
I was curious about that.
That's great
Okay.
questions. Anything else?
Anybody else? All right. Our leader, Kyle, you're up.
Okay. Let me read around the lines as I mark them up. Just another reminder that letters are going out about that prior event. The bidding on that process has been done. They've selected a vendor, so those should be going out any minute. Our China is wrapping up a community health needs assessment. I was told not to call it China anymore. And I sent it in our weekly update, but just as a reminder, we are working with Jimmy Ed to be a spoke, and that Hub and Spoke grant should be roughly $7 million over the next 5 years to bolster and increase our ability to treat cancer patients. So we're working on that. Christy and others did a ton of work to get that done in a very short period of time, which is very, very grateful for that. I've already talked about our family practice OBs. We did reach out to CAS. We've discussed this before. They did agree to partner with us to find a derm. We've had our first initial meeting to kind of hash out what that's going to look like. So that process is ongoing. I believe we are reaching out to the recruiter, or they are reaching out to the recruiter. We are. So
Great.
we hopefully will land a dermatologist of our own soon. I was going to ask, so we had many of you guys send us possible new board members. To make that work effectively, I think that whoever suggested them should go to the initial meeting with me, because it's very easy to say no to a new face, not so hard to say no to a friend, or harder to say no to a friend. So Ruth will be working starting next week to set up those meetings, and so she'll be coordinating with you guys to get that going. We did have some resignations from the SCMC as well, so we'll need to talk about somebody moving over to be the board representative on that board. So, I think that's all I've got.
Okay. I want to speak to the community on the Shelby County Medical Board of Directors as well as the Medical Court Board of Directors. If you're interested, we would love to have you call us and let us know that. It's a great board. Our hospital is terrific. Kyle reminds me again and again how blessed we are to have such a facility in a small town. But we need leadership. And so we would love to have anyone who's interested to give us a call, and we'll be happy to talk to you about what it means to be on the board of the hospital board or the medical court board. Hospital board probably has a little more time commitment than the medical court board, but it's doable. So I would like people to, consider that carefully. Do we need to approve the addendum to the physician services agreement with SCMC?
I can talk about that when I do the budget.
Okay, great.
It's your turn.
Okay, so just a couple of things to follow up with what Jeff was talking about moving to the Morning View building. So the business office, the medical records, the coding staff is what has gone down there. And that was really to free up this area, the care coordination, outside referrals, us referring outside, authorization requirements, all that is just continuing to grow. So we have a really good team right now. We've expanded to 16 members of what we call the MAC office, which is the Myrtue Access Center is what that stands for. And so, we take a look at all the orders that are placed by doctors for either referring patients out or doctors that are outside of our facility getting orders that patients can have stuff down here. Working through, we have 2 RN nurse navigators that review the charts and stuff to make sure a patient meets the requirements to have surgery along with their physician, does all the prior authorization, but it's all gotten really a lot more complicated. And all of these RHT grants are all about coordinating care between the rural facilities and the more metropolitan facilities, because we can't offer everything in the rural communities. So that's just gotten to become more and more, and they've been separated by a different manager from the nursing staff versus the revenue cycle piece of it, and kind of separated in the building because of space needs. So we've pulled that department together underneath one manager, and they will be located where the coding staff was before. So we just really needed more business-related type patient coordination type room in our facility to put that staff. And a lot of our business office and coding staff is remote anyhow. So it just made sense, and it's more financially responsible to use the facility we already have and do some minor renovations soon than it would be to build new, because it's much more expensive, especially for office space. So the MAC office will move in there. We're gonna have some other moves within internally to free up more space for OB to have some more space for our growing number of births that we're having. So we're just kind of trying to position ourselves. So centralized scheduling is up in the OB area, and at a large part of that floor that could be more labor and delivery rooms or other type rooms. So when the east side of that building down there is done, we will move them out. But to free up space and kind of move, we're doing it in 2 phases. So that's kind of what's happening there in the business office scheduling and MAC office. So the financial reports, we hadn't gone through April yet. So the April consolidated report is up here. We continue to see a 3.3% increase in our outpatient visits over the first 10 months of this year compared to last year. Emergency room visits are up 7.8%. Surgical procedures are up 20.5%. Our rural health clinic visits, this now is combined with the mental health services because they're all in one rural health clinic, is down about 2.2%. Average daily census is down 1.4%. We were up quite a bit here in the month of April of this year compared to last year. So we've been fairly busy in April there. We have 11 births compared to 4 last year in April. We were at 95 for this year compared to 90 last year. So continue to see that grow. Year to date, we're up 11.9% in operating revenue and 9.2% in operating expenses. Our other non-operating net is down 33.1%, and that's a combination, again, of Return on investments because we've used our investments to pay for our facility, and we do have some debt, so that's the interest too. So, but we are at 4.7 million, net income from all sources through 10 months of this year compared to 3.8 last year, which was a 24.4% increase. Again, this is just, I'm trying, 10 months comparable for the last 4 years. You can see there where our services have gone and just have continued to grow in a majority or pretty consistent in almost every area. And continue to grow our revenues there. And as you can see, when started to get the DPP money, we've seen quite a bit of increase there. But we'll go ahead and go through May, and then you can approve them both at the same time. So May is through the 11 months of this fiscal year, so we're almost getting closed up here in the next week and a half. Again, our outpatient visits are up 4.9%. Our emergency room visits are up 8.3%. Surgical procedures are up 17.9%. You can see here in the month of May, we had a pretty busy month in our rural health clinics. We're up 8.9% now for the year. And this is kind of going to get a little messy here, and I don't really know what to do with it, but we'd always kept track of behavioral health separately, so I can't really combine that in any one area at this point. I may just take it off of there just so it's not more or less confusing. So our average daily census, we're still at 7.26 patients per day for this year compared to last year of 7.19, so we're up 1%. So we, like I said, we've been really kind of busy. 13 births in May of this year compared to 6 last year. So now we're up to 108 compared to 96. So we've seen a 12.5% increase in that. Operating March was a little bit down in some areas. Our surgical procedures were down quite a bit. About 40 procedures in May compared to April. That's a pretty substantial hit on things. But we've had some downtime with the booms and vacations, those type of things. So as you can see, for May of this year, we had a loss of $124,539 compared to a $35,000 gain last year. There are some reclassifications in there that I don't feel like I can go back and change previous months that have already been approved, so I put them through this year month. So year to date, we're at 4.6 million in net income compared to 3.5 million last year for the 11 months ended, which is a 20% increase. So still doing very well financially. So any questions on the 2 financial reports?
Why don't we have a motion to approve the April and May financial reports?
I'll make the motion to approve.
We got a motion and a second, I'll bet. All those in favor? Aye. Opposed? Oh, thank you, Jim. All right.
So we did have our tax budget approved back in March, but we also do an operating budget when we get more into the details of each departmental budget. I meet with each departmental and each department manager, and we go through kind of their plans for the next year. So and then took a very detailed finance committee. We met on June 19th and with Kate and Jim, went through a very detailed explanation of everything, kind of pull everything together and make sure that they are in agreement to bring the budget forward to the entire board. So we took care of that and they were fine with that. So just going through the summary, we are looking to do an 8-point, so an 11.8% increase in total operating revenue. So that's the net operating revenue. And that is really looking at a result of doing some pricing increases, which are normal, taking a look at ortho still ramping up, OB ramping up, changing our mental health to the RHC makes a difference for us financially, so that increase is based on volumes and pricing increases. So, then if we look at our total expenses, we would go up to 13.6%. That's a result of, bringing on new services. We're gonna have additional supplies, vendor cost increases, our contractual obligations. Depreciation is a big increase for us over this next year because we have had a fairly large construction project, which now will be depreciated after we put it in use. So that's almost $1 million increase there. And then salary and benefits, we do build in an estimated increase that we would anticipate in January, but we will do that evaluation with later fall, October, November, and take a look at the IHA survey and also see where we are financially at that point in time. So with that being said, the proposed budget accounts for a net income from all sources of $4.2 million for next year. Capital budget, we do a 3-year plan for our capital budget, looking at what we feel like is a priority this next year. What is a contingency? We always like to build in a note if something's giving us a little bit of problem. We don't necessarily think we need to replace it yet, but we want it on there so that we know to be watchful of it. That always comes in a little bit higher than what we ever think, physically we can do, financially we can do. The last couple of years, the board has approved a $4 million funded capital projects. So this year, some of our major projects on the list, other than just replacing operational equipment, surgical scopes are kind of a high dollar on there. The concrete at the Peterson Family Wellness Center is a priority. We'll have a little bit of work yet to do on our facilities for the Morning View building. Second floor of the RHC is in here. And converting some of our OB area into more labor and delivery rooms. Those are some bigger projects that are on there. Mindray upgrade, which is Mindray is our monitoring system for our patients. That's something that's pretty much end of life that we got to take a look at. So those are our big ticket items there that will be funded out of operations. In the capital budget, we really don't account for some of our bigger master facility planning. So MRI falls into that, which is about a $2.4 million cost for that addition. We did pull down $2 million on our debt that was approved to help cover that cost, and the rest of that will come from operations or our reserves. So the $4 million capital would come from reserves, and the additional $400,000 for the MRI. Of those $4 million, there's about $287,000 in there that if we get the cancer RHT grant, it would cover that, plus a bunch of additional. There's probably $600,000 in the 5-year course of equipment that was on our capital budget that could be covered by that grant. So we probably will be spending more if we get that grant than the $4 million, but it would be covered by grant dollars. So again, the Finance Committee met on the 19th and then went through it and recommended that we bring the budget to the board. So any questions on it?
What is the cap for individual capital purchases that sometimes comes to the board?
It's 100,000, I believe now. Anything under 100,000, Kyle can still approve.
Right, I didn't know if I thought it was increased at one point.
It was 50,000 and it went to 100,000.
Okay.
Yes.
All right.
Yeah, so anything, even if it's in this capital budget, if the purchase is over 100,000, it still come back to the board at that time.
Okay.
Good question. Any other questions for Christy?
There are.
I would make a motion to,
Oh, wait, Christy's got more to say. Go
Well,
ahead,
no, I was
Christy.
just gonna say, there is about $675,000 in that revenue that is for grants, so that accounts for a little bit of that, and it'll cover some of those costs that are included as an increase too.
It's helpful. Okay, Jim,
I would go ahead and make a motion to approve the budget as presented by Christie today. Her and her team have put a lot of work into this, and they really went a lot of detail of what we had the other day that Kate and I sat through, and I think they did a really good job coming up with a plan.
I agree. Is there a second?
Second.
All those in favor? Aye.
Uh,
Okay, all those opposed? Okay, any other business that we should?
So let's go back up to the SCMC. So as part of that budget, we worked through a budget with the SCMC because they employ our providers, and based on historical, we pay by an RDU, relative value, which is assigned for each service by Medicare. So we take a look at the budget, take a look at how much the RDUs we would anticipate, and then pay Myrtue pays SCMC per RVU. That increase for the next year is 1.8%, so it'd go from $113 to $115 per RVU. So that's all just based on basically the volume of services that are provided by those providers. So we have to do an amendment to that contract each year to set that rate.
Do you need a motion for that?
Yeah.
Okay, so I'm gonna entertain a motion to increase the RVU by 1.8% from $113 per RVU to $115.
So moved.
Is there a second?
Second.
All those in favor?
Aye.
Opposed? Okay, thanks, Christie.
all right.
Thanks, Jim. All right,
I'm a little slow today.
yeah, that's okay. Any other business that should come before the meeting? The group? And there are a couple of notes that we have a system-wide quality improvement meeting coming up on July 15th in the boardroom, and the Board of Trustees meeting, our next one will be July 28th at noon. Anything else the board would like to bring to the table? Okay. I'll entertain a motion to adjourn.
So moved.
Second,
I'll second it.
I call us adjourned. Thanks, Jim.
Thank you, guys.